Hi, I'm Robert Frazier, and this is my benchmark assignment for corrective exercise, and so thank you for watching. The impairment that we'll be looking at today is low back arching in an overhead squat. So the region that we will be assessing is the lumbopelvic hip complex as it presents in the low back with muscular dysfunction. As you can see, we can assess this from the lateral view. And so when we perform our overhead squat, this is what it's supposed to look like, but what ends up happening is that you can see this low back arching happening in these patients with this movement impairment. Assessing for this movement impairment matters because it can cause symptoms like low back pain and cause chronic issues like lumbar hyperlordosis. And then there's also potential issues like herniated discs, which are not good. So the main muscle compensation / impairment we'll be looking at is between our hip flexors and our gluteus maximus. Our hip flexors will be our overactive muscles and shortened muscles, which will cause this anterior tilt at our pelvis. And our glute max will be our underactive muscle, which will not provide enough hip extension when we go into our overhead squat. And so essentially what happens is our erector spinae acts as our main hip extender, and this essentially shifts our movement from our hips to our low back, causing that arching, which is not good and can lead to those problems like I described earlier. And so what we'll be assessing in our inhibitory technique is our TFL, one of our hip flexors, and then we'll move on to the full complex in our lengthening technique as I show you the lengthening stretch. For our inhibitory technique, we'll be performing self-myofascial release on our TFL, a hip flexor, because our hip flexors were shown to be overactive. And so this is just lowering the activity of them. To perform this, you'll want to roll this tennis ball onto the TFL, which goes here and goes down. And then you will find a tender spot and you will hold for 30 to 90 seconds until the pain alleviates. You'll do this daily unless specified otherwise. The scientific rationale for this is it alleviates trigger point pain symptoms and also stimulates the autonomic nervous system. Some contraindications of self-myofascial release are patients with osteoporosis, as this would be hard for the bones, and then just any open wounds, again, would not be good to roll over those. For our lengthening technique, we will be doing a half kneeling hip flexor complex static stretch. This is to lower the muscle spindle activity that might be causing this muscle to be shortened and increase recurrent inhibition, which lowers the excitability of the motor neurons. So to start the stretch, you want to get in a half kneeling position and extend your hips to get that stretch in the hip flexors. You want to do this daily for 1 to 4 reps, 20 to 30 second hold. 65 and older clients would want to do this for over a minute. And the scientific rationale is that stiffer muscles work harder. And so if we can increase the flexibility of these muscles, they won't have to work as hard and won't have to rely on other muscles to compensate for it because it is back to its original length. Just some precautions. Our geriatric patients might not be able to get into this position. And then if we have a muscle strain, a contraindication, we would not want to do this because it might irritate that strain. For our isolated strength phase, we will be performing a glute bridge to address our underactive glute max. This improves intramuscular coordination, which in turn improves synchronization, activation of the motor neurons within the gluteus maximus, and increasing firing rate. And so to perform this, we will get into a bridge position and we will push off with our heels, extending our hips. We will do this 3 to 5 days a week, 1 to 2 sets of 10 to 15 reps. And the key thing is a 2-second isometric hold followed by a 4-second eccentric letdown. So that's how we perform it. Some precautions are just special populations like geriatric patients who have like a hip replacement might not be able to do this. And if you have arthritis, the contraindication, that'd be hard to do. For our integrated dynamic movement, we will be doing a squat to overhead press with this weighted medicine ball. We filled it with liquid to ensure that it is low load so that there is optimal alignment within our biomechanics, so that we can properly reteach the glutes to have intermuscular coordination with the surrounding muscles. And so to perform this, we want to get with feet shoulder width apart, squatting while also pressing our weighted ball. We would do this for 3 to 5 days a week of 1 to 3 sets of 10 to 15 reps with a slow and controlled tempo. And so yeah, this is reteaching our underactive glute max to work with our muscles around some precautions or some special populations like geriatrics who have osteoporosis might be hard. And then if we have an acute injury in our hip or in our knee, this would not be good to do. This has been my corrective exercise benchmark. Thank you for watching.